of mobile and electronic devices. A number of items under Chair's business. Obviously, we've had the ministerial statement today in relation to reform of the system. I think whilst people will have lobbied for and will be very clear on the need for reform, we equally need to see the meat on the bones in relation to both the collapse, if you like, of the Health and Social Care Board and the local commissioning groups, and increased accountability directly to the Department from the Trust. So I'm seeking agreement, members, that we request that the Minister and the Department comes in front of the committee at the earliest opportunity to outline the proposal and the ways forward. Sure.
Just a brief comment on what's been said. First of all, to say that I welcome movement on this very important topic. It's a long time coming, and whilst it's only a two-page statement, I think, there's probably a lot in it, but it needs action. We're long past the stage where there's statement after statement and very little action. I was at a gathering last night in this building with eminent surgeons from all over, and obviously we were talking about transforming your care and the Donaldson report, and the delay in any movement was topical, which continues to add to the depressing state of the health service in general, particularly waiting lists. I mean, I was sitting beside, I was sitting beside an eminent surgeon last night, and he was saying that some of his patients have to wait up to 88 weeks. 88 weeks, and this is for cancer. And unless and until something is done quickly, that is going to continue. If this moves us forward quickly to where we want to be, it's a good thing, but we don't want any more dragging of feet.
No, and I think, all of these conversations that we continue to have are directly linked to the way the system is currently configured. There's no doubt about it. It is complex, it's overly bureaucratic. Decisions, and even in terms of accountability around how decisions are taken is not clear. So I think that's why there's an urgency on the Minister and the Department addressing this committee about how this is now taken forward and putting more meat on the bones in terms of all of those issues.
There's one thing came out of it where he did state who was running the show. Members will know that on different occasions we have asked who is running the health service. He said he was running the health service. I hope that he continues to do that, and when things go wrong, he will take responsibility. For up until now, accountability has been few and far between.
Okay, yes, Fergal.
I'm sure the Minister and his colleagues don't necessarily agree, but in his speech, at least he's acknowledging that a great disservice was done to the public by the in-out strategy of the DUP. He's talking now about getting rid of the board. This was a board that the DUP allowed to swell to vast numbers, and now we're going to get it disappearing off into trusts and into the department, and we would need reassurance that in fact the motivation there is proper transparency and accountability, and I'm not as convinced. He's talking about money being available. As Finance Minister, he never made it available for the health service, and he hasn't demonstrated as Health Minister he's been able to get access to the money that is needed. Our job as politicians and a committee is to critique and analyse what the Health Department and the Minister is doing, and he's proposing a summit where it seems that we're all supposed to rubber stamp his future plans. It will not be happening. I hope that we would like to see, as a committee, I think we should see any plans coming before us that we can properly critique them, but some sort of an open door to whatever you're having yourself, health policy, isn't going to work in our book.
Okay, Michael?
Just very briefly, I think it's important that the Minister comes along and explains what's going to happen, because as I understand it, the board personnel will simply move into the department. Like, one thing we understand and has been clear over the past couple of decades, civil servants can't run the health service. they're unaccountable, it becomes over-bureaucratic, and they become more and more divorced. There is one issue, of course, it will make the Minister, it exposes the Minister much more to criticism, so that's, I think, is to be welcomed. There'd be no question of hiding behind the board, but the key element in all of this is commissioning, and that's the key element, and the trusts being held the account to deliver on that commissioning, and the inclusion in the commissioning groups of doctors and nurses and health professionals and so on, who, as far as I can understand, over the last 2 or 3 years just simply haven't been listened to, and the commissioning plans have gone adrift. So how all this is put together, I think it's important. But what we've seen is the board has just got bigger and fatter over the past 2 or 3 years. And what we don't want is all that just sitting straight back into the department, which has been slimmed down enormously over the past few years. And now it looks like we're going back to what was effectively the bad old days.
Okay, so I'm Tom. Sorry, you indicated.
Yeah, I do think it's a fair comment that we need the Minister here to again go through this in more detail and to explain to the members exactly his rationale for going forward in this particular way. I don't think it's any bad thing to reduce the bureaucracy within the system. I think that is something that has been called for quite some time. So I think it's whenever the Minister has brought forward proposals or suggestions on a way forward here, then I don't think we should be criticising him for that. But certainly we do need him here to go through his proposals with us. And I do know Mr McCarthy said he had a 2-page speech. It obviously shows that Mr McCarthy didn't read the speech, because it so happens that the Minister's speech that I have covers 10 pages. So it shows that he didn't obviously maybe read it. But and saying that, leaving that aside, perhaps maybe in future it will take more cognizance of it before it comes out with such a statement. But I do think that we do need the Minister here, and I support that fully, that we as a committee bring him along and then put our questions to him when he's here and let him answer.
Well, in fairness, the letter to the committee was 2 pages.
There you go. Thanks, Chair.
The speech is something separate. But I mean, I take the point. I don't think anybody across society would argue about the need for reform and reducing bureaucracy. I suppose as a committee, it's our responsibility to drill down on what those proposals actually mean now. And I think, with a degree of urgency, we would welcome the fact that the Minister will come in and address that. Pam, would you indicate it?
Yes, just to say that I think we actually need to hear from the Minister and drill down on the subject, as you suggested, before we actually condemn him right from the beginning. I think we need to hear from him and hear the full proposals. I don't think anybody would object to removing duplication and to increasing accountability.
Michael knows all about it.
It's a good news story.
Okay, the members agreed to request the Minister comes in front of the committee at the earliest opportunity to address his announcement today. Okay, just a couple of other items under Chair's business. Obviously, there's been recent media reports as well in relation to children with potentially deadly heart conditions. The fact that they were waiting almost a year for a first appointment with the hospital doctor. So I'm seeking members' agreement to write directly to the department for an update on what is going on here in relation to the Children's Heart Services Network. Joanne, yes.
I know I have many constituents who this is the life of their child, and the fact they had such hope and aspirations of retaining the service in Belfast, and then reluctantly accepted the fact that it was going to Dublin, or their children were going to have to go to Birmingham. So that worry and that fear has been exacerbated by that headline and that real concern that they are having to wait so long for an appointment for their children. So I think if we could do anything to progress that or to alleviate those concerns, because these are their children's lives, and you just can't put into context the amount of worry that this is causing them currently.
Okay, members, that's agreement to do that. Also, just seeking agreement to request an update from the department on the action plan on waiting times that was referred to, if you remember, at the evidence session with the Permanent Secretary last month. We've had no information to date. Seeking agreement that we seek an update on that, but is a very critical and important issue as well. Members in agreement? Okay, item 4, members, is the draft minutes of the meeting on Wednesday, the 21st of October, which are at page 75 of your meeting pack. Are members content with the minutes?
Yep.
Okay, item 5 then is the human transplantation bill. Briefing from the bill sponsor. We're just going to ask Joanne to move seats here. So Joanne's kindly agreed to brief the committee today. The bill and the explanatory and financial memorandum are on pages 80 to 105 of your meeting pack. And there's also a copy of the responses to the consultation at page 106. So you're very welcome, Joanne. We have Andrew Cromwell as well, who's assistant to Mrs Dobson, and Mr Donald Carnduff, who's a member of the Northern Ireland Transplant Forum. So I'm just going to, at this stage, and hand over to yourselves, invite questions initially from members once you have given your overview.
Thank you, Chair, and I welcome the opportunity to be here today on the other side of the table to brief the committee ahead of the second stage of the Human Transplantation Bill. This is the second time which I have come to the committee to brief members on changing our local laws on organ donation. The first time was in October 2013. Then I was joined by consultant nephrologist Dr Aisling Courtney from the City Hospital, representatives from the Northern Ireland Kidney Patients Association and Northern Ireland Kidney Research Fund, William Johnson and John Brown, and also Up for Life's Joe Brawley. Donald Carnduff, who is the father of a successful liver transplant recipient, and can I just say, Chair, his son Philip is a very successful gold and silver winner in the recent World Transplant Games, and certainly very, very proud of what he's achieved. Donald is with me today. I would also like to welcome my assistant Andrew Cromwell, who has been assisting on the drafting of the bill from the very beginning. I suppose, unusually for myself, I would like to begin with a quote from the First Minister, who, when asked by Joe Brawley and Shane Finnegan from the opt-out system, said, and I quote, "If somebody dies in hospital, they need an organ, so the family are asked. How is that different from the family being asked in an opt-out situation?" And I think this is a very, very key and crucial point. I certainly welcome the support of the First and Deputy First Ministers and from members across the Chamber for the bill. I would also like to commend the support I have received from the volunteers and officers of the local and national transplant charities who work so hard to promote organ donation. You all know my own personal reason, through my son Mark, for bringing forward the bill, and the fact that I believe that the issue of organ donation and transplantation is and should always remain above party politics. We get much criticism in this building for failing to bring forward legislation which makes a real benefit to the lives of people right across Northern Ireland. Few issues then could be more important than a bill which increases life chances, giving all our people, our constituents, greater hope for a new life and organ transplant. Medicine has moved on considerably since the organ donor register was first introduced, and I believe that as a devolved region of the UK, with the right to frame our own legislation, we should follow the lead of the Welsh Government through their Health Minister Mark Drakeford AM and my colleague Anne McTaggart, MSP in Scotland, and get behind this bill as a real opportunity for everyone in Northern Ireland. I would say at the outset, however, I'm a single MLA, using my own member of staff to, alongside the Bills Office, bring forward a bill of this extent and this importance. I obviously do not have the Health Minister's army of staff and resources, or indeed the First or Deputy First Minister's equal army of staff to bring forward this bill. That's why I'm happy to work alongside any member on any aspect of the bill. I would welcome input, help and assistance in bringing it further through the Assembly processes. I'm also looking forward to a close working relationship with the Department of Health and have had a preliminary meeting with the Director just earlier this week, and would be hopeful that this will provide help and assistance in the weeks and months ahead in relation to achieving the right bill for Northern Ireland. I am certainly open to improvements and changes which will achieve the right bill for Northern Ireland. One of the things which I have learnt over the past few years bringing forward this bill is that our local organ donation system is complex and confusing. Even though we are one of the most giving people with a wide support in society for organ donation, we still have a 50% refusal rate. Yet at the same time, 68% of our donations here come from people who have not interacted with the organ donor register. So with your permission, Chair, I will break down the bill in terms of its content for members. But I think it's fair to say that of the 22 clauses, the most important are towards the beginning of the bill. The first clause places a duty on the Health Minister to promote human transplantation and to conduct a yearly campaign to inform the public as to how the new opt-out system would operate in practice, including the role of the family in affirming consent. The second and third clauses set out the requirement for there to be appropriate consent before a transplant can be lawfully conducted, and covers in detail the two types of consent. Express consent, where the individual can either provide their own consent for a live donation or has engaged with the organ donor register to make their wishes known, or appoint two advocates, or has placed their wishes on a will. This is the current procedure, and for donation after death is subject to a procedure conducted by clinicians where the family are required to provide express written consent to confirm the individual's wishes prior to donation proceeding, and the bill makes no change whatsoever to that current practice. The second form of consent is deemed consent, where there was no interaction between the individual and the organ donor register during their lifetime. It will be deemed that they would have provided the necessary consent for transplantation to proceed. However, and I think this is very crucial, as I have always said, this consent is subject to family affirmation prior to donation taking place. That's why having the conversation amongst family members and loved ones is so vitally important, and I've always said that a duty to promote, which is contained in Clause 1, would be central to increasing that public awareness. You will know that I am not one for statistics, however they do highlight the stark reality faced by local people when it comes to organ transplantation, and I will spend a little time to lay out the current facts as I stand. The first and perhaps the most stark is that 17 people died last year while waiting on a life-saving transplant. The local average is 15 people each year. In 2013, 932 local people underwent dialysis, a 3 times a week life sentence. But in a sense, they're the luckier ones, as there's no dialysis for people needing a heart, liver or lungs. The only option for them is to find an organ or to die. The plain truth about organ donation is that the number available does not meet the demand, and that in a nutshell is the reason why a change in legislation is required. Finally, Chair, I would like to focus on the finances. Whilst no one can ever put a price on what it's like for a transplant recipient to receive a new life, and I certainly know this at home, there will inevitably be costs and implications for this bill. Assembly Research have conducted a research paper which looked into the implementation costs of the legislation, and it is estimated that this would be over 10 years, between £2 million and £5 million. However, the cost-benefit to the health service of increasing transplant numbers are quite startling and could be as much as £7.4 million net benefit to the Northern Ireland economy. To give you just one example, and focusing on kidney patients for a moment, the average cost of keeping a patient alive through renal dialysis is £30,800 per year. I mentioned earlier that in 2013, 932 local patients underwent dialysis. That meant a total cost of over £29 million to the health budget, based on NHS cost estimates in 1 year alone. Each kidney transplant roughly costs £17,000 per patient, and post-transplant the yearly cost of immunosuppressant medication is roughly about £5,000 per patient, meaning that for each kidney patient who received a transplant, the NHS estimate that received a saving of £25,800 in the second and subsequent years. This does not take into account the benefits of people returning to normal society, the impact on their families, community, and in fact the wider society, and their normality in life. It's very clear that the current lack of available organs is placing major stresses and strains on local patient families. One of the major reasons for this is that all transplants for local patients, with the exception of kidney transplants, are conducted in hospitals in other regions of the United Kingdom. Liver transplants for adults are conducted in King's College Hospital, London, and for children in Birmingham Children's Hospital. Heart and lung transplants take place in Freeman's Hospital, Newcastle. So imagine the long and difficult trips back and forth to these hospitals, the anguish and pain while they're living with their condition while waiting on an organ. The lack of available organs means that patients must endure more trips from home to hospitals across the country at a considerable strain to them and their families and considerable cost to the health service. Increasing availability of organs increases life chances and decreases stress as well as financial costs. Recent figures from the British Heart Foundation reveal that there are currently 10 people in Northern Ireland waiting for a heart transplant and 1 person waiting for a heart and lung transplant. And according to latest NHS transplant statistics, no one from Northern Ireland has received a heart transplant in the past year. So just imagine the stress and worry on those 10 patients and their families. I know I was not alone amongst the organ donation community in being absolutely delighted to hear the fantastic team at the City Hospital recently undertook 5 kidney transplants in 1 day back in September. Whilst a one-off, it does show, in terms of kidney transplants, we have the expertise and we have the capacity. But I'm very conscious that's a one-off event, but I'd like to see more people given that chance of life. For some, a transplant is not an option, and they're resigned to the fact that they will end their days in dialysis. For others, it's all about giving hope. And I'm thinking in particular of one family that I know where 12 members have a genetic renal condition. A family who will never know how their children, how long their children will have until their kidneys fail. So just imagine for a moment what providing hope to that family would mean to them when faced with an uncertain future of dialysis for any of their family members. Hope that a new life will come, and with this bill, I firmly believe will deliver that hope to the families. I was also absolutely delighted to see the new organ donor register being launched back in July across the UK as a result of the Welsh Act 2013, which comes into force next month. These changes included provision for people to be a donor, to not be a donor, or to nominate 2 advocates to help affirm and make that decision for them after death. And can I also welcome the fact that the Health Minister, Simon Hamilton, welcomed these changes, but would point out that we would need legislation to come into place through the Assembly to enable us to avail of these changes, which I understand our health service has rightly paid their portion for, so this bill will enable those changes to happen. I would like to hand over to Andrew to give a short overview of public attitudes to organ donation and a change in the law, if that's okay.
Thank you very much, Chair, for the opportunity to present, and I suppose I didn't have the option of opting out of this occasion, so I'm sorry for that. Just to focus a few comments, I wanted to talk about the consultations, because there have been 3 which have taken place on the issue of organ donation in recent years, and the first being the members' consultation that took place, as well as the PHA's consultation into public attitudes, which was in June 2013, and also the Public Health Agency's most recent, and I think those figures are from February 2015 of this year. That was the Public Health Agency's attitude survey on organ donation. In relation to the bill consultation, there were 1,366 responses to that, and that was a mix of online and offline responses. And also we had a general public responses, as well as from charities, councils, churches, health and social care sectors, and from political parties and others as well. And a summary report of that was produced at the time, just after, in the next month, in October of that year, and that gave an overview of the 10 questions and the responses that were given to those 10 questions. And that showed, in summary, 82% support amongst those respondents to changing the law and to moving to a soft opt-out system. There was also 61% support for retaining the key role of the family and 86% for protecting the rights of those who lacked capacity in the legislation, and those are things which are reflected within the bill. The report on the response to the consultation is available in the Assembly Library, and it equally gives responses which were positive towards, and it also raises and gives some examples of concerns that were raised to each of the questions as well. So it gives a flavour of the views that were expressed when people took the time to respond to that. The Public Health Agency survey at the same time, which was June 13, highlighted 56% support for a move to a soft opt-out system, and that was in 2013. That has now risen in their most recent one to 61% of the public supporting a move to a soft opt-out system. In 2013, when responding, 18% of those, and I think there were 1,012 respondents to the Public Health Agency's consultation, 18% of those were opposed to a change in the law towards a soft opt-out system, and in the 2015 figures that would be now 10%, so that figure has fallen. So that shows in a way that attitudes have changed, possibly as a result of the continued hard work that the charities have been engaged in over quite a number of years, and I know that they are keeping up the pressure with the opt-out campaign and with their own continued work, and also the PHA's very important Speak Up, Save a Life campaign. I think that has been an instrumental tool, and I think the PHA's influence in doing that and bringing that forward has been something that has been extremely positive to the organ donation community, whether people are volunteers, family members, or anyone who has any connection with organ donation can take solace in the fact that that has been a very successful campaign. In the response to the PHA's 2015 survey, 79% of those who responded, and I apologise for the continued statistics, agreed with the statement that a soft opt-out system will result in more lives being saved as a result. The figure in 2013 was lower than that at 74%. Interestingly, that when Wales decided to go down the route of a soft opt-out system, and that was through the Welsh Government making that decision, when they looked at public attitudes in Wales, they found that 49% of the public in Wales were supportive of changing the law, and at present we have, from the 2015 figures, we have a 61% figure according to the Public Health Agency. So that in a way shows a clear evidence of public support from the majority of people towards changing the law. And in a way, a final point that I'd like to make is about bedside rejection. We have currently quite high rates of that in Northern Ireland. We can see that in other opt-in countries in Europe, the average refusal rate is roughly between 45 and 60%. I think Northern Ireland's is in and around the 45% at the moment. In opt-out societies, that is tends to be lower, in and around 2 to 15%. And I think if we look at the Belgian system, they're closer to the 2%. So I think that shows that in those countries, it is clear that the conversations are taking place and happening, and that when it comes to the time of asking the family whether they knew the wishes and can confirm the wishes of their loved one, they are in a better place to understand what those wishes are at that time. I believe in a way as a society that's the direction that we should be moving to, because we need to give hope to those people who are waiting, and we also need to ensure that there are fewer people who die as a result of waiting on our current disparity between organs that are available and organs that are not available. So thank you very much.
Chair, is it okay if I leave the final word to Donald Kernduff, the father of a liver transplant recipient and long-term support and advocate for organ donation?
Thank you. And can I start by thanking you, Chair, for the opportunity to talk to the Health Committee and to share some of my experiences and some of my views. My story is not dissimilar to Mrs Dobson's. 11 years ago, in the summer of 2004, my son and I were on Africa on a Habitat for Humanity building project. And shortly before we returned home, my son was weak, listless, sick. On the way back, he was jaundiced and even more sick. He was taken straight to the Royal on the Saturday morning when we got home. He was air ambulanced from the Royal 48 hours afterwards to King's College in London. On the Tuesday evening, I was staying with my sister, who lives 30 miles from London. My wife was staying in accommodation very close to the hospital. My wife phoned me at 8 o'clock on Wednesday morning to say that I should get up to London as quickly as possible because my son's liver had packed in completely. And I got the train up to London with the news that my son had suffered acute liver failure. At the time, I knew nothing, next to nothing, about transplantation. What I did know was that there were a lot of people who needed organs, and there weren't enough organs for those people to be restored to health. I assumed he was going to die. We'd been told that if there wasn't an organ available, he would not last until tea time. And on that train journey up to London, I was sketching out his funeral. It was then it was a surprise, and if the word pleasant applies in circumstances like that, it was a pleasant surprise that there was an organ available. Our surgeon talked us through the processes. My son went into theatre at about 3 o'clock on Wednesday afternoon. The transplant went ahead, and he was released from theatre at 1 o'clock in the morning, and thereafter was on life support and intensive care for 8 days, and those were long and difficult days for us because every day there seemed to be a different problem, and the different problems that arose at the beginning of the day were potentially lethal problems, and we watched him unconscious and life support, battling with those problems with the help of some incredibly caring and professional people in intensive care. And 8 days afterwards, he was woken up and has had a long and quite difficult journey since then. But now, at the age of 29, he is in decent health. He has lived, I think, a life. The life that he's got back is a life that he has lived in a way which has caused us enormous pride, and which I think honours the second chance of life that he was given by his donor and by the people who consented consented to the donation. He has competed in the British Transplant Games on several occasions. He competed last summer in the World Transplant Games. As Mrs Dobson has told you, he won a gold medal and 2 silver medals at the recent World Transplant Games. He is working full-time. He's heavily involved in youth work in the church that he is associated with. He lives a life that's so busy that we barely see him. And I think that he has honoured the gift that he was given and made the most of that gift in a way which makes us immensely proud of him. And during that 11 years, I have had some very powerful and surreal experiences, and one of the most surreal and moving experiences is the fact that for me, the most significant person in my life, outside of my immediate family, is somebody whom I never knew. The 48-year-old woman whose liver restored my son to life. I think about her every day. I think about her family, who made the call that that organ should be donated every day, and it's a surreal and moving and in many ways a privileged position to owe so much to somebody whom you never knew, to owe so much to a dead stranger who really only interacted with your experience and with the people that you love after she had passed on. So during those times, during that 11 years, not a day has gone by when we haven't thought about that lady and her family. And it has been a defining experience in our lives. And my wife and I have done our best in the years since my son Philip had his transplant to encourage people to think about donation, to promote the organ donor register. I've given talks to various groups and turned up at freshers' fairs to talk to young people who are going on to university courses about organ donation, and it has transformed not just my son's life, but has transformed our lives as well. And through all that work to promote the organ donor register, through all those casual and informal conversations with people about organ donation, I have thought long, and through all those hours thinking about people whom we never knew and will never know, to whom we owe the life of somebody whom we love. I've thought long and hard about what the legal position should be on an opt-in or an opt-out system. I've weighed up the arguments over a long period of time. I recognise that any argument about the best legal position has to balance a lot of powerful arguments on either side. It has to balance the profound and deeply personal relationship that every human being has with his or her own body, with the need for everything possible to be done to ensure that very ill people don't die. And currently, since April 2015, there have been in the United Kingdom 1,969 organ transplants, and there are still over 6,000 people waiting for transplants. So that balance in terms of the way in which society regards organ donation and the way in which the law legislates for it is a very, very difficult balance. But having thought about it long and hard, I believe that a soft opt-out system, such as the one that Mrs Dobson's private members' bill proposes, is a soft opt-out system that still allows families the final decision is the way that we should go. And my support for it is based on two arguments, and I'll try and articulate those arguments as clearly as I can. The first is a statistical argument, and a statistical argument that indicates that the countries in Europe with the best donation rates, measured in terms of donations per million of population, are the countries that have some kind of opt-out system. Recent EU data showed that in 2013 there were 4 countries in Europe with more than 40 kidney donations per million of population, and those countries were Spain, Austria, Croatia and France. Now, that same EU data showed that the only countries with over 20 liver donations in 2013 per million of population were Portugal, Belgium, Croatia and Spain. And it would seem, looking at that evidence, that the countries that have some form of opt-out system in law are the countries with the best donation rates. Now, I recognise, and I've thought about this fairly thoroughly, I recognise that it's far, far more complex than that, and that changing the law isn't in 5 minutes going to generate better donation rates. I recognise that I personally would not support, for instance, the kind of hard opt-out system that applies in Austria. I recognise that other features apply in terms of donation rates improving, the presence of specialist nurses to talk to bereaved families, the regularity with which brainstem death is tested in ICUs, the retrieval procedures for organs, all those facets of medical and clinical infrastructure are valid as well and contribute to increased donation rates. But the statistics at the end of all that and weighing all that up, the statistics are quite clear. The countries with some kind of opt-out system have the highest donation rates. And as somebody whose son would not be alive without organ donation, and as somebody who knows people who have died waiting for organs, I would be keen that we have as high a donation rate as it's possible for us to have. So that's the first reason why I support the general principles of the bill are those statistical reasons. The second reason is that I am convinced that a change in the law will generate a different culture within Northern Ireland, and a culture whereby talking about organ donation is not something to feel squeamish about, not something to not bring up in polite conversation because it's a subject that some people feel uncomfortable about, but will create a culture where the need for donation and the decision about whether you wish to become a donor or not is spoken about more comfortably and more openly than it currently is. I've worked steadily to try and promote the organ donation register. There are currently 650,000 people on the organ donor register in Northern Ireland. That's as high as it's ever been. And all that is the product of some steady and committed work by bodies like the PHA and by dedicated individuals. But essentially, being on the register is no guarantee that the people closest to you, the people who will have to make the decision in the event of your dying in circumstances where you can donate organs, no guarantee that your wishes will be known by the people closest to you. I have spoken to any number of young people at Freshers' Fairs about organ donation. They've said, oh yes, I support that. I'm on the register. And the next question is, does anybody in your family know? And from time to time, the answer comes back, oh no, I haven't told anybody about it. I would be embarrassed to talk to my family about it. So the fact that you're on the register is no guarantee that come that awful time when somebody in your family might have to make a decision about donation, that those people will know what your wishes were. And as Mrs Dobson has already said, most donations come from people who weren't on the register and whose families will have to make a decision which may well be based on their own innate compassion at the time, because a conversation about organ donation has never taken place within the four walls of their home while that person was alive. So as I see it, a change in the law which will be accompanied by the sustained and regular public awareness campaigns that must come with the change in the law before it's actually in place. I think that must surely get people in Northern Ireland speaking about organ donation in a way that they aren't speaking about it at the minute. And if that happens, I think it will lead to a situation where grieving relatives are more prepared for the question when it comes, and where the answer to the question respects the wishes of the deceased. So in short, I would favour an opt-out system because the statistics suggest that it works and is a factor in increasing organ donation rates. I would also support an opt-out, soft opt-out system because it will, I think, help create a culture where people can talk openly about organ donation, so that should the awful situation arise when someone can become a donor, some of the anguish is lifted from a grieving family and the wishes of the dead are honoured and life is restored to an ill person by a gift freely given. Again, I'm very grateful to you for the opportunity to share these stories and these views with you as a committee. Thank you.
At this point, but thank you, and particularly Donald, because it's difficult to share your own personal experience, and appreciate. I had the opportunity to meet with these recently, and I mean, there's no doubt that it is very impressive, the achievements of your son to date, in the face of a lot of adversity. But I thank you for that and for being so open today. I suppose specifically my question is around the consent of the family, and I suppose in a scenario where someone has expressly opted for organ donation, then after the person has died, some family members are opposed or strongly opposed to that, and I appreciate, Joanne, you're saying that family involvement is critical, but as I understand it, the bill would generally empower doctors to proceed with organ removal in those cases, but even if they would have the legal authority to do so, I'm interested on your view that it would be inadvisable for doctors to proceed in the face of opposition by a family. How?
Sure, I think it simply wouldn't happen. The doctors would consult with the family, and if the family were opposed to it, it simply wouldn't happen. Those views wouldn't be overridden, because when a family is faced with imaginable agony of losing a loved one, there's no clinician or doctor would compound that grief and that despair. It simply wouldn't happen. So be assured, as current happens in practice, the family are consulted, but it's a very, very difficult decision, and I think Andrew referred to it in his about bedside rejection as well, that it's very great in Northern Ireland, but there is the possibility within this bill to appoint advocates as well to carry out, so your wishes are carried forward. So there's the role of the advocates. In fact, that's in the new organ donor register, which will go live in Wales next month. There is that facility to appoint advocates to carry out your wishes too.
Okay, thank you for that. And there's a number of members who have indicated. Kieran first.
Chair, thanks very much. Thanks very much, Joanne. It's nice to see you sitting at that end of the table instead of sitting there. But anyway,
It's nice to be here, Kieran.
yeah, now you're grand to first class. First of all, to congratulate you to getting to where you're at and the enormous work you've put into and your dedication to see this thing through. And that's all the aid of saving lives, as you and Donald have experienced in your own family. And that's a tribute to the work that you have done. And I wish you every success as you go along. And I hope and pray that it will come to fruition. I just have a couple of questions, and that is, do you have any estimates regarding the increased number of potential organ donors through the provisions of this bill?
Thank you, Ken. Could you ask again your question?
Yeah, when the bill goes through, do you have any notion of how many extra? Aye, that's right.
Well, if one life is saved, it's worth doing. Obviously, as Donald highlighted as well, this will be, I'm thinking of Northern Ireland, not now, not currently when this becomes, I'm thinking of Northern Ireland 10 years down the line, when organ donation becomes the norm rather than the exception. So one life saved will be crucial. That will make it worthwhile if only one person can be saved. But it's hard to define how many will be saved, but obviously in tangent, as Donald has outlined, with Clause 1 of the bill is the duty in the Department to promote transplantation. So that will be a yearly promotion to inform people about transplantation, about the laws changing as well. So that will all tie in with the change in the law, and this bill, if all goes according to plan, will become law in May 2018. So with the public awareness, with the wonderful work that the charities are doing, continue to do and have done for many years, it will, as time progresses, save lives. But if one life is saved initially, it's worth doing.
And I think you said there was it 17 lives that were lost this
17
year?
local people died last year
While waiting
on a
organs?
transplant, yes. The local average is 15, and last year it was 17. So it's alarming that people are dying waiting. And one thing as well that I have been told by people that I have engaged with during my journey with organ donation, they need hope. And I spoke briefly in my submission at the start about a family that I know personally with 12 members with a genetic kidney condition, and one of those members said to me she's looking at her two sons and wondering, will they, she knows at some point, because 12 members have a genetic kidney condition, when it will happen for them, when she sees her mum who's on dialysis but will never get a transplant because of other complications. And she's saying, as she says, the future of her two boys spread out before. And if anything, it gives hope with the change in the law that things can change and they will have that quality of life rather than watching her brother and her mum and other members of her family sentenced to a lifetime of dialysis. So hope, I think if when people have hope and the hope of the change in the law, I think it makes a big difference too.
And just finally, how quickly do organs need to be recovered in order to be successfully transplanted? And do the checks and balances or safeguards in the bill provide sufficient time for the transplants to occur?
Well, obviously care and time is of the essence, and I visited last year the NHSBT headquarters in Bristol early last year, and all transplants in the UK are coordinated through that one tiny room in Bristol, and that's where they make the phone call to the patients. They match the organ to the patients, and it was quite a surreal experience for me, as you can imagine, because when I was visiting that room, I knew that's where the call came on the 5th of February 2009 for my son Mark, that the call would have come through to that very room that gave him back his kidney. My experience with it was that when Mark got his transplant, Northern Ireland was covered in a layer of snow back then, February 2009, and time was of the essence. His kidney came from mainland UK, so at that time the city airport was closed, and we got the call about 6 a.m. We were in the Royal Belfast Hospital for sick children for 8 a.m. waiting on that life-saving kidney coming in the airplane. So there's usually with kidneys that they like to do it within 12 hours. Obviously, the sooner a transplant can happen, the more useful the organ as well. So there is that window to get the transplant done. So any delay, if there is a delay or they're experiencing a delay, then it will go to the next available, match the next available person. But with kidneys, it's slightly longer than if you need a liver, as Donald has experienced with his son, or heart or lungs. You would need to be in the hospitals in mainland UK waiting on that transplant coming, and certainly that window of opportunity is a lot smaller than it would be with kidneys. But time is always of the essence. If the transplant is delayed or the organ is taking longer, obviously the effectiveness of a kidney is 24 hours, it probably a 3-year time frame of it lasting. So we're trying to get the best transplants that last the longest, but that's my experience with it. But kidneys would be more resilient to others.
I wish you all the best and
Thank
every
you.
success in your endeavours. Thanks, Chair.
Thank you, Kieran. And Alex next.
Thanks, Chair. Joanne, thank you for your presentation. Excuse me, I've got a cold, so I'm a wee bit funny. Right, I'm trying to get my head around this, so I hope you don't mind me asking you some awkward questions. I take it from what you're saying that in the soft-out option that basically everybody in Northern Ireland will be sort of on it unless they opt out of it. Is that basically what we're saying?
They go on, they have so many options. If I take you through the clauses with the bill, they can, there's basically 2 forms of consent. Express consent, which is similar to the present system, but with the ability to opt out and the inclusion of advocates, which is new. And the new change in the law, which is deemed consent model. And that deemed consent model is with family affirmation. So you can express your consent that you want to go on the organ donor register. You can express your consent, you can appoint 2 advocates, but you can also opt out, opt off. So if you choose not to, if for some reason you're not, don't want to become donate your organs, for the first time ever, your family will never be approached. Currently, everyone can be approached by the clinician for organ donation, but if you're vehemently opposed to organ donation, if you chose to opt out, that simply won't happen. So that, in essence, strengthens your human rights, because that simply won't happen. They'll never be approached. The new change in the law is which is clause 4, is the deemed consent model. So if a person has not engaged with the organ donor register or expressed their wishes during their lifetime, their consent will be deemed. But crucially, and this must be confirmed by an adult in a qualifying relationship, and it does not apply to those who haven't lived in Northern Ireland for 12 months or cannot understand the concept of deeming consent and doesn't apply to excluded material. So I said from the very, very start, when I laid out my wish to plan this bill, that I want a family veto, that family affirmation on the face of the bill, that the family has the final say. So with the Welsh model, it's an objection, deemed consent objection model. Mine would be your family or your advocates have to affirm that you would be keen to have your organs used.
Okay, so is it right to say then, as soon as you're born, you're on it, unless you opt out?
No.
No.
It doesn't apply to children.
So from 18?
Yeah.
Right, okay. Okay, and say theoretically, we'll use Upper Ban, there's 77,000 people on the electoral register roughly. Well, it's actually 77,903.
Okay.
But taking that aside, so say half of them decide to come off it, and say the other half decide to stay on it, and they're all, if their family consent, you theoretically could have, say, 35,000 organs being donated. Would that? I know it's a simple way to say it, but is that in theory that could happen?
Do you want to answer this?
No.
Yeah.
No.
Can I maybe come in at that point? I think what you were saying about going onto the register, it would be at the time of death that the deeming would take place. So it wouldn't be a matter of people going onto the register during their lifetime or being put on a register against their will, I think was where you were possibly coming from, during their lifetime. If there has been no interaction with the organ donor register throughout their lifetime and the individual has not expressed their consent, someone could have done that by putting their views in a will as well. But again, Kieran talked about the window of time, and I think a will is perhaps an unadvisable way to do that, because by the time that process goes through, it would perhaps be past the window of time that would be required. But no one would be put on a register against their will. It would be at the time of death that it would be ascertained whether they had interacted with the register in any way, whether to opt themselves off, whether to appoint two advocates to deal with the matter on their behalf, or whether to opt themselves on and say, yes, I would like to be a donor. If there has been no interaction at that time, the legislation would deem their consent subject to the family affirmation and being asked the question. So I think that perhaps answers your question about that.
Right, but we'll get there.
Okay.
Okay, so say there's 20,000 deaths and all of them are agreeable to having their organs donated, say, in 1 year. So that would probably outstrip how much is needed in organ donations in Northern Ireland. Would they then be able to be used outside of Northern Ireland, the rest of the UK?
Well, it is a UK system. My son's kidney came from mainland UK. It is a UK-wide system, anyway. But
So we can,
As did my son's organ.
right, okay.
but it's the circumstances in which it happens. It's if you take, I think Donald referred to you have a good analogy about the amount of 26.
The donation rate, very, very simplistic, the donation rate in the UK is 26 per million donors. Sorry, I beg your pardon. 26 donors per million of population. And when I talk to young people about organ donation, they very often assume that if they join the register, they will be donating organs. The fact of the matter is, if they join the register, you get very, very long odds from Paddy Power that they would ever be donating organs. 26, the way I explain it to you, perhaps simplistically to young people, is 26 donors per million population. If you imagine the last day of the Premier League season, where all the games in the Premier League kick off at the same time, every stadium that has every stadium that hosting a home game is packed to capacity. If you imagine those football stadiums filled across England, 26 people within those stadiums will be organ donors. So that gives you an idea of how rare it is for people to die in circumstances in which they can donate organs.
Right, okay. You mentioned about clause 4 about the family right to object. what happens if they were faced, I think you'd answered it, but if you were faced with a scenario, maybe a child had died and the father was sold for transplant and the mother wasn't, what would happen in that if there was a clash of conflict?
Well, obviously, a lot of faith and confidence would be on the clinicians and the decisions they would have, and that's why I think it's important, as Donald said earlier, to have that conversation. That's something you find currently hasn't been happening to a great extent. But obviously, the family wishes would be taken into. They would sit down with the specialist nurses and the doctors and the clinicians to discuss it, and there's not a clinician would proceed if there was going to cause anguish or distress to a family. It simply wouldn't happen.
Right.
And for what it's worth, this is only anecdotal, and it perhaps may not, in your view, have any weight because it's only anecdotal. But I know 2 families who agreed to the donation of organs of a teenager who was killed in a road traffic accident, and in both cases, both father and mother were in agreement that this was the right way to go. And I can't even begin to understand the anguish of losing a child as they did. But down the years, the fact that they made that decision together has brought them a not considerable comfort, but some comfort. Has taken some of the edge off their anguish. Now, that's not to say that in other circumstances, mother and father might not agree as readily as these people did, but from the people whom I know who fit the scenario that you're talking, they were in fairly firm agreement, and having made that decision, it has taken some of the edge off their grief down the years.
Okay. In terms, say, there's no family member and there's maybe like friends appointed, who appoints those friends to decide?
You'd appoint, you have the option, if you're expressing your consent, for example, of appointing advocates, and that's aligned with the new organ donor register, which went live in July. There is that opportunity to appoint advocates. Those are people that you trust implicitly, long-standing friends or family members, but that's your wish to appoint those advocates to act on your behalf.
What happens if you're facing the scenario where somebody doesn't have a family and something happens, God forbid?
If
something happens, there's an accident and you can't locate a next of kin or a family friend, what would happen in a scenario like that?
If nobody on the list of qualifying relationship, well, it wouldn't happen.
It just wouldn't
Clinician
happen.
wouldn't put family through that anguish.
Okay. My last question for you is, you mentioned about the costs which would have to be met by obviously the health department. What would those actual costs be? What would those costs entail?
The cost of implementing the bill?
What would that all be?
Well, that would be, obviously we have a fantastic programme here in Northern Ireland already, so those specialist doctors are already in place, but there would be obviously a change with the infrastructure and change in the law. The findings I referred to earlier in my speech from the Assembly research would be the cost of between 2 and 5 million for the first year. Now that's something which, as you can appreciate, I'm a private member. I don't have the departmental figures because they're only coming on board now to help as the bill progresses. That's something will be worked through with the department. I had a meeting this week with the senior director, and that's something needs to be costed going forward. But the initial consultation and the initial work done by the Assembly research was that it would take between £2 and £5 million to implement. They have quite a detailed cost analysis. That's over 10 years, so it's a minimal sum of money over 10 years. Crucially, I think, which is important as well, the change that we referred to and Minister Hamilton welcomed, which went live in July to the organ donor register to allow for the advocates to allow you to opt off as well. This was brought in to facilitate the Welsh Act, which goes live in December. So crucially, that will enable this to be done as well. But those costings will be were between 2 and 5 million, so it's a minuscule sum of money compared to, as I've alluded in my presentation, the cost of keeping someone on dialysis, the cost of 932 people on dialysis and that vast amount of money compared to the cost of actually getting a transplant as well. But as I said earlier, you cannot put a price on the human cost and the elation of getting that life-saving transplant and getting your loved one back.
Thank you.
Thank you.
Just for clarity, in terms of that issue around, you know, a family opposition, for want of a better word, in a scenario where you're saying that a clinician or doctor would not proceed in that opposition, is there something specifically in the bill that you could point us towards that you maybe set out for us?
There is a reference in the bill to a conflict, which is what Alex was talking about there. If a family member took an opposing view from another family member, and I think the central point in that, in a way, is what we should be getting at is the will of the individual who has passed on. I think that's the central point in that, that their wish should be. But if there is a conflict, I think there's a reference in the bill to guidance within the Human Tissue Act 2004, from my memory, within the bill, that those set out and assist the specialist nurses who are fully trained at that time to approach a family at a time of grief. And I appreciate it's an extremely difficult time for that family, but I understand there is provision mentioned in the bill that is already there within that Human Tissue Act, because that could happen at present. Under the current system, we could have a conflict.
Can you just maybe, Andrew, I mean, because this is an important point, point to where it would be that issue about reference to conflict or within the legislation itself?
I understand it's in the schedule. I apologise, Chair. I'll try and find it here.
Okay, it's in
If
the
a copy,
schedule.
Chair, the schedule's obviously at the very end of the bill.
Okay, I mean, again, given the importance of this, is this not something that you would consider that would need to be in the bill itself? You know, this does seem to be one of the the biggest areas here.
Well, it's in the schedule, Bill, but Chair, but I am certainly, as I said from the very start, willing to work with any member on any amendments or anything to improve. I want the best bill for Northern Ireland, and if there's any concerns or any wishes to bring forward, happy to take those on board and work with it.
Okay, now there's a number of members that indicated. Pam next.
Thank you, Joanne, and in particular to Donald for sharing with us today, which is obviously a very, it's a very emotive subject. It's a very sensitive subject, I'm sure you'd agree. And you'd mentioned the word uncomfortable. I think that's quite true amongst many. It is an uncomfortable subject as well. And I would say it's controversial on top of all that. But I would like to say from the outset, I am one of the, 653,000 registered people on the register, and have been since becoming an adult. It's a decision I made a long time ago. I've always had a concern where there's no way to overcome the fact that somebody else in my family can actually overcome my wishes. Because I feel so passionately about organ donation, the fact that actually someone, say next of kin, would be able to override my wishes. So are you saying with the advocates that you would say, take an example, say a wife decides that she wants to donate and she names two advocates, but her husband is completely opposed. So in that situation, should the opportunity to donate arrive, who makes that final decision?
Well, obviously, if she's had that conversation, and I'm delighted that you are so supportive of it, obviously, if she's had that conversation with her husband and knows he's vehemently opposed, and it's her wishes, it's her body, and as Donald outlined earlier, it's important that your wishes are carried out. That would be a situation, it would be a rare situation, very, very rare situation, but it's good that the conversation would take place, because then you'd know the wishes. But in that situation, if you were a supportive organ donation and your husband was opposed, that would be your right. You could put it in a will, as Andrew spoke of earlier, but will is time-bound as well, and we know time is of the essence. But that's where you would appoint your advocates to carry out your wishes.
So just to be clear, Joanne, in that scenario, then the organ or organs would be donated.
If you have specifically specified, went on to the register to express your consent and appointed your advocates, and or if you wanted to go on in your will, a point that you support organ donation, you want your organs to be used, and your express wish that that goes ahead. It would be very, very rare, Pam, it would be very, very rare that if a married couple and they were at conflict with each other, I can't see my husband intervening in my wishes to be.
Well, I can very much see it, but
that's
I
why
really want to
this-
clarify.
the
So
same-
in that situation, you would see the advocates.
Well, the advocates would
the
be somebody
advocates would-
that you choose
Yes,
to
but the
carry out your
advocates-
wishes.
Then the next of kin could not override that
That's
decision.
why you appoint.
And you think clinicians would be content?
Well, if you have put down that you're two advocates, and that's a facility that came into force in July with the new organ donor register and will be on this bill, if you want your wishes known and you're a supportive organ donation, you appoint those two people in law and on the register to carry out your wishes.
Yeah, as you were speaking, I was trying to put together a kind of screenplay of the situation that you were alluding to, and it's a frightening screenplay. And it's a situation where you're balancing two, to use that horrible term, nightmare scenarios. On the one hand, somebody who loves the deceased person but is passionately opposed to organ donation, even though he or she knows that the deceased person was in favour of it, is going to have his anguish, his grief, his sense of loss exacerbated even further by the sense that organs are going to be taken from the person who's just passed on, whom he loves dearly. And then advocates will be asked to make the call, and advocates will say that we were nominated and we know that she wanted her organs donated. And there'll be all kinds of stresses and strains within a family, and presumably friends of that family, which will last for years afterwards. And it could be a very, very it could be a very painful and a very, very unpleasant situation. But in my mind, that needs to be balanced against the wishes of the deceased. And the wishes of the deceased, I think, need to be honoured. And balancing two horrible situations, I think that is the right way to go. And I do know one person who is in a similar situation, who is passionately supportive of organ donation but knows that her family, particularly her children, are strongly against it and have told her that if she ever dies in a situation where she can donate organs, they will say no. And I think for that person in particular, the fact that advocates have been allowed for under the terms of this private member's bill would be a very good thing.
Okay. A good thing for the wishes of the donor, but obviously not a good thing for the next of kin who could be traumatised over it. But yes, that's very interesting. Thank you. I absolutely agree with the need for the conversation. I think that is vital, absolutely vital. And I know there's some people who have had that conversation and can't get that agreement. I know cases of just families who just disagree. Plain so, just disagree. So I think it is very important to have that conversation. Do you see your bill as a way as a mechanism to force that conversation?
Well, Clause 1 of the bill from the very, very beginning puts a duty on the department to inform the public on the change of the law and the conversation. So that will start that, and that will happen once a year to inform them about and have that conversation. I think Donald alluded very well in his opening comments earlier, the fact that so few people particularly the young people that you refer to, have that conversation. So anything that preempts and makes that conversation happen is crucial. And that's why from the very, very beginning and in the very first clause, I put in the bill the duty on the public awareness campaign. And the public awareness campaign will promote and stimulate that conversation. But that will, and the fact that the law will be changing, will allow that conversation to take place. But it's crucial. I think we need to educate people on it, and we need to communicate, and those are two very, very key points that need to happen.
Okay, thank you. Donald, you spoke about your son and the 48-year-old lady whose organ saved your son's life, and that's tremendous. Would you consider that a gift?
I'll be very frank with you. I would like to consider it a gift. I don't know whether this lady was a willing donor or not. It may well be that she was, but I never told her family. It may well be that she was and had told her family. That's what I would like to think. It may well be that she had never considered organ donation in her life and never talked to anybody about it, and that the family made that very courageous call without knowing what her wishes were. It may well be that in her heart she was violently opposed to organ donation but had never told anybody. Mm-hmm. And again, the short answer to your question is I don't know. I would love to think that it was a gift willingly given. I hope it was a gift willingly given. The gift has been received and honoured by my son regardless of the circumstances in which it was given. But the short answer to your question is I don't know.
I'm just concerned with the idea, and it has been presented to me in the past, that some people would consider it, for them to have their name on the organ donor register, that is a gift that they're offering, should the circumstance arise. But that some of those people would be wary of, the idea that in some way the state would almost own their organs, and that removes, the gift that they're given. And I have heard some people express their disquiet to such an extent where actually some people would say, I'm on the organ donor register, but if this was brought in, I would actually opt out. Would that be a concern that you would have, that you could actually lose people off the organ donor register?
That's a very, very good point. Andrew, you have the details on
It's
it?
a very valid point, and actually it was one of the questions in the PHA's initial 2013 public attitude survey. And when they questioned their 1,012 people, there were 2% who said they would fall into that category, that if the soft opt-out legislation came through, they would consider that they may remove themselves from the organ donor register. So you're quite right, it is a valid concern there, but I think it's all about making sure that the wishes of the individual prior to death are then carried forward after death. And I mentioned earlier some of the bedside rejection statistics that we have in Northern Ireland, where people are on the organ donor register. We have a rejection rate of in and around 45% because they have put themselves onto the register, and as Donald mentioned earlier, perhaps haven't had that important conversation with the family. So at a time of very difficult time for a family, when faced with that question, they then don't know, and perhaps choose that the best option for them is to say no because they weren't sure what the wishes were, and they are wanting to honour those wishes, and with not knowing, they perhaps choose to say no. And I think the figures that we have are that in opt-in societies, it's slightly different, where there is a much lower bedside rejection rate, which perhaps shows that the opt-in system in those countries is, as you say, precipitating the question. And I think it's important that if we take a look at next year or the year after, that may not necessarily be the case, but it's a rolling. If we look at Clause 1 with the education, it's something that will gather steam, and I think I did pay tribute to the PHA's Speak Up Save a Life campaign. If we have that year on year, we can look at a system that would encourage the conversation and that would mean that at the time of asking, and the statistics for opt-in in other countries, including Belgium, are roughly between 2 and 15% compared to our 45%. And I would like to think, when Donald mentioned there about the gift freely given, I would like to think that the decision of the families to consent to that means that they have had that conversation and that they are knowingly carrying on the wishes of their loved one after death.
Okay, thank you. Just finally from me, Joanne, if your legislation is passed and it resulted in an increase in available organs, what guarantee is there that people in Northern Ireland would benefit?
Well, as you know, it's a UK northern wide, and my son's kidney came from mainland UK. So we're going to benefit already with the Welsh change, which comes live next month with their legislation. So we're going to benefit from there. So both Mark's kidney and Philip's liver came from mainland UK. So we're already benefiting from, we'll certainly benefit from the Welsh change, but similarly you can't say where the organ will be used within mainland UK, but it will be make that more organs are available, and you wouldn't want that because it goes into the pool. It has to be always about the best match to fit the need of the person.
I just wanted to clarify that there is no guarantee that a rise in available organs within Northern Ireland, it doesn't necessarily mean that there are more organs available to the people in Northern Ireland. It is UK-wide.
It increases the chances, but and as I said, with Wales, with the Welsh Act coming into effect next month, hopefully people in Northern Ireland will benefit from that as well. But it's UK-wide. Thank you. Thank you.
Michael, next.
Thanks, Chair. Thanks, Joanne and Andrew and Donald. I can start by saying from where I came from a few years ago as the Minister of Health, I would, and knowing what I know, I very much support this in principle. And I understand that the devil is always in the detail, but I think you've certainly gone a long way to dealing with the issues and thought them through. And as far as I can see or clearly see, choice ultimately is absolutely the key principle. And I think we're all aware, Chair, that we're talking about life here, and we're talking about saving lives. And I vividly remember, as the Minister going up to Children's Hospital and meeting a child, a wee boy of somewhere over 2, who was tootling about on his tricycle. It was actually the hospital tricycle, and that tricycle supported his liver, because this was a wee one who needed a liver transplant. And he was tootling about with the all hooked up. And I asked the clinician, what's the prognosis? The clinician said, it's very bleak, very difficult to find a liver. He needs a new liver, to get a liver the right size. As things stand, very bleak. And I think that's when you meet babies like that in that situation, I think in principle, we've got to find a way to be able to do this, and I think that's the position I come from. Also, a fact that we talk about kidneys, and we have a notion that, well, if your kidneys fail, dialysis can pull you out. But the reality is dialysis will work for a period, but then after a period, dialysis stops working. And I had a close friend of mine who was just a couple of years older than me, who 2 kidneys failed, was on dialysis for 5 years, and we lost him last June. He needed a transplant, but at 70 years old, he would not have been near the top of the list. So I think what we're talking about here is life itself. As far as, and I listened to Pam's concerns, and I think they are very, very valid questions. Explain again how the choice works, because it's deemed consent. If you go on the register, and I'm on the register, and if you're on, everybody will be deemed to be on the register, but that's not the end of the story. And if you come to the point, and in most cases donation won't occur, because in most cases you're not going to get the match at that particular point in time. But in those cases, how does choice work? And the other issue then, and just because of this week and where we've been through this week, these are issues that actually go to, there can be often a religious connotation with this as well. Have you got any sort of church objections, or do you get objections and no's, or can we say that the churches don't have a problem? I know you have the charities in support, but very often you get a sort of a fundamental Christian objection coming through. And just where we've been this week, I'd be interested to hear that, because I've heard that in the past from where I was. But to me, the key thing is supply and demand. We don't have enough organs, so therefore people who are losing their lives are coming to harm. They're feeling. We're part of the UK-wide system because that benefits us. We do well out of the UK system. If we were only looking at our own narrow pool, we would be worse off than we are. It's a bit like blood donation. We have to get support from blood banks UK-wide. We can't do it all on our own, and that's the reality there. So, but if you just run through those couple of points there, the key thing is choice.
Okay. Well, if we can start with the latter one on the consultation, and Andrew referred to the consultation, 16-week, very extensive consultation that we carried out. And like Andrew, I was delighted with the PHA's consultation as well, the 2 subsequent consultations after the one that I carried out. One objection was lodged from a group at the consultation. It was a group called CARE. And when I met with Dr. Mark Bailey, then after that, he came to my office. As I said, I wanted to engage with every single one. I wanted as wide a consultation as possible. I wanted everyone to make their views known. Once we went through the detail of it, and he was reassured that the family veto that on the face of the bill, he withdrew those objections. So those were the only objections. We did meet extensively with church groups. We met with so many different groups, and that was the only one that objected, but the CARE did withdraw. I think they have incidentally supported the Welsh model. CARE Wales has been very, very supportive of Wales as well. Going through the first part of your question, Michael, the 2 forms of consent that with the bill will be express consent, as I said earlier, were similar to the present system, but the ability to opt out, which currently, if you were opposed to organ donation, your family could still be approached. So if you want to opt out, it's quite simple. Your family will never, ever be approached. So that, I feel, strengthens for the first time your rights if you have a reason that you don't agree with organ donation. And the change in the law, clause 4, is the deemed consent. So that again does not, I think Alex was quite good earlier in his line of questioning, and we teased that out considerably. That will only happen on your death. If a person has not engaged with the organ donor register or expressed their wish during their lifetime, their consent is deemed, but crucially, as I said earlier, this must be confirmed by an adult in a qualifying relationship. So that's that family veto, that affirmation, that safeguard, in essence, from the family. So that's where the choice comes in. But you have the choice to express your consent. You have the choice to, as Pam highlighted in her questions as well, which is very important, appoint 2 advocates if you wish. You have the choice to, for some people, and Donald referred to it earlier, was the ick factor. They don't want to think about organ donation. They don't want to maybe make a decision either way. So they have the opportunity, if they are not minded either way, to support or not, they really can't make that decision. They can appoint, if they wish, 2 advocates on their behalf to make that decision for them, and that's the ick factor, because it's a big conversation, and we might have our ideas of what we feel for organ donation, but some people simply don't want to. They don't want to opt off, they don't want to opt on, but they want to appoint advocates. So that will be facilitated within the bill as well. So I think, essentially, I think all choice and everything is covered in it. Do you want to comment on?
Yeah, I think the ick factor was one of the things that the PHA survey looked at as well, because I do remember Dr. Eddie Rooney, I think he presented to the committee at that stage as well, referred to that, and I think the advocates is a powerful way, because it is a new tool that is coming in. It's a powerful way of enabling someone to choose two people, and it prompts the conversation, because inevitably when you're choosing two people and providing their details across to NHSBT, it's a natural assumption that you then have that conversation with those people and that they're au fait with your wishes. Equally, if you don't wish to think about organ donation, but through the promotion that will go on through Clause 1 in the bill, you decide that you wish to interact with the register but just can't come to the point of making that decision yourself, you have the new power and new ability to be able to choose two people to make that decision for you at the time. And I think those are two very important strengths of the advocate system.
I could say PHA support.
Well, certainly the work they've done through their public attitude survey as well, and Andrew referred earlier, the Speak Up Save a Life campaign. I do remember at the launch, I think it was of the first Speak Up Save a Life survey, Dr. Eddie Rooney, I remember it well, going to the launch of that, and his opening remarks, which will probably haunt him forever, which I noted were, if he was a member bringing forward a private member's bill on organ donation, he would be happy with the findings of that report.
Okay, thank you. I have three more members have indicated. Tom first.
Thank you, Chair, and thank you, Joanne, for your presentation today. And Donald, again, whenever you have a personal touch, then it always brings it home much more. For someone who has experienced it and gone through it, it certainly does bring it home to the members today. But Joanne, Spain was mentioned today, and Spain is known as obviously as the world's best in the terms of donation rate. However, back in 1979, Spain passed.
1979?
Yeah, I was. I mightn't look it, but I was. But back in 1979, Spain passed presumed consent legislation. And that failed, that didn't work. And so what they did 10 years later in 1989, they went through a crucial organisational change, and out of that they created an organisational infrastructure for transplantation. And now they're known internationally across the world as being the best for donation rate. Now, what I want to know is, what do you deem this different about this bill that you're bringing forward as presumed legislation that's going to close that gap, in a sense, that didn't work in Spain? What is the difference there?
Well, you come back to 1979 for a start.
Yeah, absolutely.
Yeah,
but it didn't work
if we're
there.
talking dates, can I, before bringing Donald, take you back to Belgium in 1986 when they first introduced the system as well, and they introduced it in one of the regions of Belgium first, and it was such a success in all the regions of Belgium, then adopted it as the period of time progressed. So, Donald, do you want to comment on Spain?
Well, I was well aware of that when I talked about donation rates in countries with an opt-out system. I said that the change in the law was not on its own going to generate significant differences. Medical and clinical infrastructure were very, very important. I'm aware of the fact that Spain is at a gold standard currently in terms of donation rates, and that was not the case for some years after they introduced opt-out legislation. My view on it may well be simplistic, but it's from my talking to medical people in Northern Ireland and trying to ferret my way through a vocabulary that I barely understand to get to the main points that they're making. My view is that the medical and clinical infrastructure in Northern Ireland and in the United Kingdom is good. There are more specialist nurses in ICUs than there previously were. The culture whereby specialist nurses take over difficult conversations that clinicians perhaps do not have the sensitivity to conduct, I think that is progressing well. So in terms of medical and clinical infrastructure, what I think is a vital bedrock to change in legislation, I think we are doing reasonably well in the United Kingdom from my limited knowledge of it. And I think that what needs to come in on top of that is a cultural change. And as I said in my own presentation, I think that the word forced was used earlier about the law forcing conversations. I would rather see it as a change in the law will encourage conversations and encourage a cultural change over years, whereby talking about organ donation is not regarded as something uncomfortable or squeamish, but something which is a very, very good thing for people to talk about. So, I think that the medical and clinical infrastructure, without which a change in the law is not going to make any impact whatsoever, is of a high standard in the British Isles. And I think that the cultural change, which I'm convinced will ensue from a change in the law, will help increase donation rates. And increase donation rates in a medical and clinical context, whereby the people who can make best use of that increased donation are already working at a very high level.
And obviously, concur. Obviously, medicine has moved on considerable amount from back in 1979, and medicines and new methods evolve all the time. But while medicine is moving on and transplants are moving on, certainly the law here is not keeping pace with medical advances.
Yeah. Well, I was only pointing out the scenario and wondering just what the difference was, but just to come a wee bit more up to date. In 2007, the UK was at an abysmal situation where there was only 809 or something that was, in the terms of donation rate, it was away at an all-time low. It was worrying. It was a worrying factor and all that type of thing, and the health organisation then set up a task force to look at this. And since 2007 until now, every year, year on year, that has increased. In fact, by 2012 it was increased by 50%, and by 2013 by 63%, and that is still on the increase. So, you know, that obviously small steps, but it's starting to come and starting to increase now. I believe for your bill to be effective, and this has been talked about today, there needs to be education, there needs to be communication, there needs to be talking about it and all this type of thing. And all I'm trying to tease out here is, if we had that education and that communication and all that talking about it tied into the system that we already have, which is already increasing and has shown from 2007 it has increased, would that then close the gap, in a sense, for want of a better word? Would that close the gap, or will this bill that you're bringing forward make even further advances to that? That's where I'm trying to get to.
No, it's a good point, Tom, and I think Andrew alluded to it when he was speaking earlier. We're thinking of Northern Ireland not just next year, the year after. We're thinking of Northern Ireland 10 years down the line, and you're completely cracked up about the education programme as well, and that's why it's in clause 1. It's the duty to inform and the education programme once a year. So that's crucial. That it cannot work in isolation. It needs to be combined with the education programme. You're quite right. We've come a long way. I'm impressed by your dates and your statistics from UK rates in 2007. But last year, 17 local people died in Northern Ireland waiting on a transplant. 17. The average is 15. So we need to do something. We have fantastic, we're blessed with fantastic charities, volunteers that do amazing work in Northern Ireland, and I have been proud to be associated with some of those charities for over 20 years. But can I take you back, if I may be personal, for a moment, the launch of my consultation a couple of years ago. I had a lady who was a member of, one of the founding members actually of Kidney Research Fund, and she was sitting in the Great Hall, and she said, "Joanne, I have worked for 42 years for one of the founders of Kidney Research, but please, do this for the people of Northern Ireland. We need to make this law happen." So despite the fantastic work of those charities, and they do amazing work, despite the fact that we still have the low 30s of people on the organ donor register. We can't get past that plateau of so few people on the register, so we need to do something. For me personally, and for the work of the charities as well, a do-nothing approach is not an option, because if we stand back, 17 local people died this year. If one life can be saved, just one, through a change in the law, I think it's a law a chance worth taking.
Yeah, I've no difficulty with that at all, and I'm looking out across the wide spectrum of people, and there are people for it and there are people against it, and those people that are against it will be feeling, well, you know, something's going to happen here that's happening against my will, in a sense, because I'm automatically going to be on a register.
No, you opt out.
No, but they're on that register until they do opt out themselves. So, you know, I'm going to automatically be on a register until such time
They're
as
not on a
opt out if I want
register.
to
It's
be.
not until if they die, essentially, that the demon kicks in. They're not on a register. If they do nothing, they're not in a register. You're in a register if you express your consent, or if you appoint advocates, as I highlighted earlier, or you're opposed to organ donation. Then you can go on and register that you don't want to be an organ donor. The deeming with family affirmation, which is the family safeguard, would only happen on death. And as Donald highlighted earlier, the fact that there's certain circumstances where that would happen, it's not an automatic green light to transplantation. So you're not on a register somewhere or list somewhere. That simply doesn't happen. You know, until if you die, then that's when the clinicians and the specialist team will go through the register to see, did you express your consent, did you opt out, or did you do nothing, did you appoint advocates, or are you not on that register? So you'll not magically go on a register where you're deemed. That simply won't happen. And that's why I think, Thomas, it's good to have that conversation to rule out that misinformation that's miraculously somewhere you're on this register, because it certainly won't happen.
Well, I think education is key, because whenever it comes to the death of a person, and the family then has to make, or they're asked actually, do you wish to do this or do you not wish to do it? It's too late, I believe, at that stage, because the family are going through a very, very difficult situation. I mean, this something happened to me when I lost my little boy, and then the clinicians asked me, or the people at that time asked me, well, do you want to donate the organs or whatever? To me, going through what you're going through at that time is certainly too late at that time. And I think that what you need to do is you need that education first of all, and you need to be talking about it, you need to be out there, and it's just, if that was done, does your bill still make a difference to what we already have in place? Yes.
Thank you.
Okay.
And George?
Thank you, Chair. At the very outset, I would like to congratulate and commend Donald on his very passionate presentation. Absolutely excellent. Joanne, the point that I would like to ask you is, you did touch on it yourself, was the excellent work that has been undertaken by the kidney transplant unit in the City Hospital, and the great achievement that they had recently, equaling the record for kidney transplants in one day, and have achieved the best live donor levels in Europe. Do you know what their views is of your proposed legislation from the consultants and the medical staff who probably carried out those operations?
Well, I've engaged extensively and I meet regularly with everyone involved in organ donation, and you're quite right, it was spectacular. No one was happier than me to hear about those 5 transplants in one day. I think there were just 1 transplant behind the record. So I think that goes to show, George, those people in the City Hospital, and I know most of them very well, they are passionate campaigners and advocates for organ donation. We have the specialists there, we have the consultants there, we have those people already there to carry out those transplants. But I don't want that to be a one-off in September 2015, that 5 transplants. I want that to become the norm. I want more 5 transplants in one day, because just think of the difference that would make the people here in Northern Ireland if that was became the norm rather than the exception. And you spoke earlier about the live donor scheme, the altruistic transplants, and certainly Dr. Aisling Courtney and her team are world renowned for that. Yeah. Interestingly, when I was in Brussels last January, I met with Dr. Luke Collenby, who's head of transplantation in Brussels and across ELISA European team. And he did explain that they have in Belgium, you do reach a point where altruistic transplant live donor scheme almost peaks. Everyone that's able to do live donation, that happens. So you need to look, and it's fantastic to be able to do that, but it's not the answer. It's great for someone to give that gift and to save a loved one through that, and but it does peak, and that's what they have found in Belgium. So we need to look at other ways. We need to look at other ways of increasing those organ donation, and I feel if we can do that through this simple change in the law, through, as Tom and others have spoken, an education programme, the awareness programme, and then for informing that those conversations are taking place, they don't become the exception, they become the normal. We certainly have that expertise here, right here in Northern Ireland, to make that happen.
Okay, thank you.
Thank you. Thank you. And Rosie?
Very much, Joanne, Donald and Andrew for coming today, and I just want to echo what everyone has said. I fully endorse what you're doing, and I'm on the register myself, so yeah, I think it's necessary. I'm going to need to leave, so I just want to ask a quick question, Joanne. In the circumstances where a person is on the register and they've no relatives that who are close by or close, and if that person then passes away and some relative pops up, would that person who maybe hasn't had contact with the deceased for a long time and has no relationship, but they are a relative, would they have the right to go against the wishes of the deceased?
Well, if the person's on as you said, they're on the register, then they've expressed their interest in donating an organ. So certainly that would be reflected by the specialist nurses, that they're so well trained to deal with these situations as well. And if the clinicians would take that decision with the relative as well, but there's a list of people in a qualifying relationship as well with it. But if you've expressed an interest and you're interested in organ donation, that would be reflected through the clinicians or to a relative, if it's a close relative or someone that they hadn't seen for a while. We have in the face of the bill people in a qualifying relationship as well. But if there's any doubt whatsoever, or the wishes would be, the clinicians would make that decision, and they have the expertise, they have the ability to make that decision.
So they could rule out that person from having the say. I mean, it's possible to do that.
If I could maybe...
Like let's say it's a sister or a brother, but who has been estranged for years,
Well, I think
and there's no other living relative, let's say.
If they have expressed their consent during their lifetime, the specialist nurse would evidently be approaching that relative on the basis of, here is the view that the individual expressed during their lifetime. So I think it would naturally follow that if there has been very little contact between that relative and the individual in those circumstances, that it would naturally follow that that individual would wish to try and carry what they knew as the only evidence that they had of their loved one's wish, which would be their signing on at whatever stage during their lifetime onto the organ donor register. So if that is the only evidence that that relative is presented with, which the specialist nurse has the ability to provide them through the NHSBT database, then obviously it would be hoped and expected that the relative would take the view that the individual had, because it's all about ensuring that the wish of the individual prior to death is carried forward.
And I mean, I totally agree that that's the way it should be. I suppose I'm just trying to think what might happen in a scenario where a person has a completely opposing view and actually comes along for the purpose of using their power to oppose. So would the clinicians would make that decision?
No, the clinicians would have an input into that decision, but naturally it would be left
family
to
members.
the relatives to work alongside, because a clinician would not conduct an operation or a transplant without there being the appropriate consent. In fact, the bill
It wouldn't proceed without the consent. There's quite an extensive document to be signed.
Yes, so that person who hasn't had contact might have the final say.
Well, currently, I think, Andrew,
would be the
you
case,
spoke
yeah.
about it. Currently, that would be the case.
Right, okay. But in the bill that you propose, that wouldn't necessarily be the case. He's saying that would be different. Is that what you're saying? Would this legislation maybe change
I
that?
think
It would be in line with
That's-
current practice.
That's similar to the question that the Chair asked earlier on about the when there was a conflict potentially of opinion as well. So I think we would be open to looking at that and to looking at the detail around what you're saying. I do take the point that if an individual had a totally opposing view and they didn't wish to carry through, but as I say, the only evidence that that individual, having not been connected to a relative, would be their expressed consent if they had provided that, and it would be hoped that the individual would use their ability as it stands at present when they're engaging with the clinicians, would use their ability to help ensure that what they were doing was not necessarily their opinion, but was the opinion of the individual prior to death.
Right, okay.
Okay, well, thank all three of you for that today. It's been informative for us as we move ahead, and thank you for taking the time, and particularly to Donald for sharing your own experiences. So thank you very much for that. Thank you. Members, just moving on. Item 6, we want to look at the handling arrangements in terms of the bill. Pages 155 to 158 of your meeting pack. Obviously now we've heard in relation to from the bill sponsor, we now need to decide our approach to the second stage, which is obviously a debate on the principles of the bill itself. So I suppose there's a number of scenarios. There's a number of ways in which we can approach this. First of all, we can agree that the committee, that the chair speaks on behalf of the committee during the debate to reflect the committee's position on the bill. Yes.
I think, Chair, given the subject, it might be necessary to go back to party, so I don't think I would be comfortable with taking a committee position as such. So I think, for my part, I wouldn't want that at this stage.
Okay, well, then there are another few options available to us, that we either decide that the chair should not speak on behalf of the committee at the debate, or that the chair's remarks are limited to just describe the briefings which the committee has received on the private member's bill. So what I'm hearing is that there's not a committee position. Is there a timeline? I'm looking to the clerk for this in relation to 16th of November in terms of the second stage.
Second stage is the 16th, but they need to decide next week.
So we would need to decide next week? Yeah, okay, so we have until next week, but there is an option there where I can either not speak on behalf of the committee, or speak and limit the comments to simply the briefings that we've heard today. So if we reflect on that and make a decision on that next week.
How long does Pam think it's going to take her to reflect her party's view? Will it be ready for this day next week, in which case then
I suppose in
the
terms
committee can express a view?
In terms of the mechanics, we would need to move to some sort of recommendation here by next week.
Does the chair reflecting the committee's view reflect the entirety of the committee's view, and therefore, if you were to see sight of the remarks made by the chair, which would honestly reflect the position of the committee, that there were a number of issues raised, would that satisfy you in terms of? I don't think that you're saying as a chair that there's one solid position, but that you're saying, I think I think I could take from the sense, and by the way, I can congratulate you on everything you've done. All the issues that I had thought of might be raised were raised already, so I didn't feel it important to add. But if we were to have comments from the chair, which honestly reflected that there were concerns round and about issues, then I think that would be reflective of the maturity of this discussion. You know, I think people were honestly probing around various different issues, genuine concerns. But I didn't hear people going, I'm pulling the rug out from under this. I get a sense, maybe I'm wrong, I got a sense that people would support some sort of a continued process here.
But I think the point, and again, we can, you know, move to a recommendation next week, but I think the point is, as a committee, we would be asked whether we would consent or otherwise to the principles of the bill. So we would be ultimately talking as a committee, in my view, at that point. So I think there's a number of options there. One of them is that I shouldn't speak on behalf of the committee. One of them is that we just limit that to what we've heard and reflect that in a manner which probably is close to 2 years.
Chair, I think, because we'd be happy to come back to it next week.
Okay, happy enough with that, thank you. So I just want to ask maybe Catherine to speak on timescales and options, obviously, in terms of the handling of the committee stage of the bill.
Okay, thank you, Chair. Second stage is scheduled for 16th of November, which means that if the bill passes second stage, the committee stage would begin on the 17th of November. The committee has 30 working days to consider, take evidence and report on a bill under Standing Order 33. If that 30-day period was applied, the committee's report would be due on the 28th of December. However, as members know, a committee can seek an extension to the 30-day period. The committee has sought extensions previously to other bills, for example the Food Hygiene Rating Bill and the Control of Data Processing Bill. Committee stages with those bills both have lasted around 6 months. Both these bills attracted limited public interest. For example, there were 15 organisations who responded to the call for evidence on the Food Hygiene Rating Bill and 23 groups on the Control of Data Processing Bill. There is no way of knowing at this stage how many organisations would respond to a call for evidence on the Human Transplantation Bill. However, in terms of previous public interest in the bill, Mrs Dobson's public consultation attracted 1,366 responses. Over 1,200 of those were responses to an online questionnaire, and there were 135 full written responses. However, in relation to the Human Transplantation Bill, as this is the last session of the mandate, there are different considerations in terms of seeking any extension date to committee stage. There is no fixed last date on which a committee should report on a bill to maximise the chances of the bill passing its remaining stages before the Assembly dissolves. And this is really because there are a number of unknown factors at this stage, including the number of other bills competing for plenary time and the fact that it is a matter for the Executive and the Business Committee to schedule plenary business. However, the general advice has been that the latest date on which it would be prudent for any committee to report on a bill is the end of January. If the committee was to seek an extension to the end of January, I've provided a very outlined timetable for the bill, which is in the meeting packs, which really allows for, and this is in the presumption the committee is just meeting once a week and within the normal term time periods, not going into any recess periods. So it would be two meetings in November to take evidence from stakeholders on the bill. One meeting in December with the private member to discuss the evidence taken, a further meeting in December for the committee to conduct its informal deliberations and come to a view on amendments that it would require, a meeting in January then to finalise those informal deliberations and make sure the committee was content with the wording of any amendments, another meeting for the formal clause-by-clause reading, and a final meeting to consider the report. This timetable is allowing 2 meetings for oral evidence, and it's not allowing time for commissioning research papers or undertaking any study visits. Linked to that issue of timetable is the matter of putting out a call for written evidence on the bill. This is usually a committee's first step in gathering evidence, and the written evidence is usually used by members as part of their consideration in terms of selecting the witnesses for oral evidence. In other words, to ensure that the stakeholders you invite to give oral evidence represent a broad range of opinions on the bill and of substantive comments to make, and points raised in written evidence by organisations who aren't called for oral evidence are usually then also put to the private member during any deliberations on the bill. The normal approach for committee stages is to issue a call for evidence with a 4-week deadline. The earliest date which a call for written evidence could issue would be Friday the 20th of November, presuming it was signed off with the committee on the 18th of November. A 4-week deadline would mean a closing date of the 18th of December. However, if the timetable which I have just described, which is only a draft timetable, was followed, the committee would have already taken all its oral evidence by that stage and come to an informal position on the bill. So a 4-week deadline would call into question how the evidence, the written evidence, would actually be used in terms of the committee, in terms of considering the bill. Another option would be to look at a 2-week deadline, but again, if that is used, the committee has already taken its oral evidence on the bill. Another option would be to put out the call for evidence with the 4-week deadline, but then not use the evidence in terms of considering the bill, or use it to select witnesses and simply include it as part of the committee's report for the Assembly's information. However, I do think the committee would need to be aware of the risk of calling for written evidence on a bill which it didn't intend to use as part of its deliberations, and would need to think carefully about how that call was worded. A further option would be for the committee not to issue a written call for evidence and to select its own stakeholders for oral evidence. However, again, I think the committee would need to be aware of the risk of not giving a wide range of stakeholders a chance to comment on the bill, particularly given the large number of people who responded to the bill sponsor's public consultation in 2013. The approach to any call for written evidence and the timetable and the extension are all matters for the committee's discretion, but I would point out that any extension sought to a committee stage of the bill would require the support of the Assembly.
Okay, so obviously, I mean, at this point, and Catherine has outlined a number of options there, the bill hasn't yet passed, obviously, second stage, but I think it is important that we start to look at those issues in relation to timetable and call for evidence. Obviously, if it does pass second stage, we'll have to take decisions then on any extension date and what our approach to written or oral evidence will be, and we will need to take that decision by the 18th of November. So are there any initial views at this point, or are people happy that we would have to return to this with a decision by the 18th, Pam?
Chair, I would be very concerned that we're not rushing this, given how important it is, and given how potentially it could affect every single one of us. I think it's too important an issue to be hurried, or that we would restrict how we take evidence or the call for evidence. I would just be a bit concerned that we don't give this the attention it actually deserves. So at this stage, I'm just saying it would be a concern, and we don't know yet what else is coming to the committee as well in between times by way of legislation. I just think it's far too important to try and scurry it through, because we're, in the throes of the last lot of months of this mandate.
No, I mean, and I have to say I share those views. Given the importance, given the level of interest, given the level of public responses, even to the initial processes, but I think there are potentially ways in which we could attempt to deal with this, and that may be scenarios around longer meetings. It may be about seeking evidence in a more, let's say, creative, imaginative type way. There are options there that are available to us in terms of maybe taking a day and bringing evidence in, taking a day specifically on this bill. But I do think that there's a duty on us to do this properly. You're absolutely right, and you know, anything less than that we would be failing on our responsibilities. So Catherine's pointed it up today. I think by next week we need to, you know, have clear recommendations on how we handle this and going forward.
Chair.
Yes, George.
Just on Pam's point, this is my last meeting. Move to environment next week or in the next couple of weeks. But I think Pam has spelled it out really well. It's too important, and I wouldn't be one to stymie the bill in any way, any shape, form or fashion. But I think it's very important that we do take our time at it and get the thing done properly and get it done right. But I'd like to thank Joanne for the work that she's put into it. And
I think that's a general view. I think people will expect us, and we would be failing in our duty if we didn't apply proper scrutiny. I think what we need to do is look at how we manage that. There may be scenarios, as I said, about taking evidence in a different way, but it also may mean longer meetings, and that's something that we reflected on some time back. So I think come next week we need to have clear recommendations on how we proceed, bearing in mind what the members have said. This is too important to do anything less than that. Okay. Okay, members, just moving on then to item 7, which is the new firefighters pension scheme 2015, which is on page 160 to 166 of your meeting pack. Just to remind members that the committee had considered and approved the SL1 for the rule on the 23rd of September. There's been no changes to the policy content since the SL1 was submitted to the committee, and the examiner of statutory rules has no issues to raise. So are members content with the statutory rule? I take it that's contentment. Therefore, I'll put the motion that the Committee for Health, Social Services and Public Safety has considered SR 2015-355, the new firefighters pension scheme, amendment number 3, order 2015, and there is no objection to the rule. Agreed?
Agreed.
Item 8 is the forward work programme, which is pages 168 to 172 of your meeting pack. I'm asking members to note. And just advising members that the evidence session with the Trust Chief Executives may have to be altered slightly, depending on the request for the Minister to come to committee, but we'll come back to people on that. 9, matters arising. There's one item at page 175 of your meeting pack. It's a response from the Department providing clarification on the Department's authority to legislate on the domestic advertising of e-cigarettes. Are members content to note?
Great, yeah.
10 is correspondence. There are 11 items at page 178 to 251. I just want to draw your attention to 2 of them. 246 is a request from Cancer Research requesting that the committee sponsors the launch of his research report on the state of cancer services in the Long Gallery on the 22nd of March. Members content to sponsor?
Yes.
And page 247 is Action Mental Health, requesting an opportunity to make a presentation to the committee on the research report by Queen's. Are members content to invite the organisation directly to the next stakeholder event?
Agreed, yeah.
Agreed.
Are members content then to note the remaining correspondence? Any other business? Do members have any other business? Okay, so date, time and place of next meeting is Wednesday, the 11th of November, starting at 2 p.m. in room 29. Thank you.